Good afternoon. This is Holly Lemaster, the Program Coordinator of the Colorado MESA Initiative, and welcome to our webinar. Today we'll be talking about documenting patient history for evaluation and management coding. I want to start with just a couple of housekeeping items. Your webinar control panel is probably floating on your upper right-hand part of your screen. If you're having any trouble with your audio, you're obviously not going to hear me saying this, but the instructions are listed there, and you can call in on the telephone versus using your computer speakers. The webinar ID is listed here. You should see a little hand-raising icon on your control panel. If you could click your hand-raising icon and let us know that you can hear me today, that would be very helpful. And I see a couple of hands going up. Okay, fantastic. Your control panel also includes a box where you can type in questions. You can type those in at any time during the webinar that your questions might come to mind, and we will address them all at the end. Also, just want to remind you that there are handouts available for today's webinar on our website at coloradomesa.org. You will need to sign in and then go to the area called Events and Upcoming Webinars. That's where you'll find those today. And then by Monday, we'll have the recording of this webinar posted in the archives. And starting at that point, you'll be able to view the webinar again and also find the handouts under the archived webinar section in the classroom. As a reminder, the Colorado MESA Initiative, our acronym stands for Medicare Experts, Senior Access, and we are here to help you all be more adept at your Medicare coding and documentation so you can be paid fairly for your good work. We are a collaboration between the Alzheimer's Association Colorado chapter and Senior Care of Colorado, and we are funded primarily by the Colorado Health Foundation with supplemental funding from the Kaiser Permanente Foundation and Caring for Colorado. So thanks to those generous organizations for making this happen today. Our speaker today is Dr. Donald Murphy, who is one of the founders of the MESA Initiative and the practice group leader of Senior Care of Colorado, and he knows a little bit about today's topic, needless to say.
I've been doing this a little bit, yes.
So he is here to share his expertise with you, and we're going to be focusing on a really deep dive into documenting patient history for your E&M coding. So Dr. Murphy, welcome, and take it away.
Thanks, Holly. Hi, everyone. Today, as Holly said, we're going to do a bit of a deep dive, but I really do want us focusing on what happens when we hit the water in that first yard down rather than the bottom of the pool. There will be an emphasis on geriatric primary care. That's our specialty. Our goal here is to help us all embrace the Medicare population. And I realize that many of you out there are taking care of younger folks. That's great, but there are some little different approaches for some of the routine stuff we do in geriatrics that I'll highlight. So the focus of this webinar is on the history. Just a reminder, we have the three components: history, exam, and medical decision-making. When we have a new patient, we have to have all three components. When we're doing a follow-up patient, to bill at any particular level, you have to meet criteria for 2 of the 3. Now, you can all imagine that the history will be involved in almost any visit you do, because if you don't have a good history, then it's hard to justify any level of exam or the medical decision-making. So you can almost count on component number 1, the history, being a key factor in every visit we do. Okay. Think of the history in these 4 categories. Chief complaint, and we'll get to each one in more particular a little later. Chief complaint, when we say the history of present illness, remember this term was kind of devised way back when, more with an acute focus. But the history of present illness includes an acute problem, or more commonly what we do in primary care is a summary of ongoing chronic problems. Either or, both, that's all part of the HPI, history of present illness. The review of systems, and then the past history, now called past family and or social, please be sure however you pronounce that. I like to think of it as PMH, past medical history. I'm going to emphasize right at the beginning, at least in primary care geriatrics, think of a medication review whenever you're thinking about the past history. That is the key. Now realize that insufficient documentation of any of these subcomponents can and often does lead to incorrect coding of the entire service. So when you're meeting criteria, you have to do it in all the different components. And as I mentioned before, the information in the history is necessary to substantiate medical decision-making and medical necessity for the visit at all. There are 4 levels of the history: problem focused, expanded problem focused, detailed, and comprehensive. Those are the terms that are used by CMS when they give you the tables. Now, note on this table, you do have to meet all 4 elements in a row of the table for a certain level. I'm going to just advise you all to think more of the levels. So, for example, in the clinic, all right, let's start at the very top, the highest level, the comprehensive. Think of a 99215. That's the code you put down. That's the highest level. The detailed would be a 214. The expanded would be a 213, and a problem focus perhaps a 212. So do get familiar with those numeric codes, if you will. You'll be able to remember those, in my opinion, better than, geez, is it a detailed or comprehensive? Perhaps not. You might prefer the wording, but know how they interact or how they represent each other. In this table, you can see, for example, a detailed, which would be a 99214. You need a chief complaint, obviously. You need a chief complaint no matter what level. On your history of presence of illness, it's going to be an extended. We'll talk about that more in a second. Basically, you're talking about summarizing 3 chronic problems, or maybe 2 chronic problems and 1 acute problem. Your review of systems, it says extended, but remember, although that extended suggests a lengthy thing, we're talking 2 to 9, anywhere in there, different systems reviewed. And then finally, you do need the pertinent past history. I'm going to point out here that a medication review, an update of the medication list, always counts as part of the past family and or social history. And at least in primary care geriatrics, that is the emphasis. Not to say that we do not at times include the family history or a surgical history or the social history. Often we include the social history. But it's that medication review that is the key over and over. So again, in this table, you see that under the detail, the 99214, these are the different things you are required. And each level will have different requirements. Next. Now, when you put down the chief complaint, you're basically saying the reason for the visit. Often, and ideally, it's in the patient's words, own words. Geez, I got a stomach ache, or I got this headache, or whatever. But given that many of our visits are follow-up of chronic conditions, and there might not be a new symptom, it's okay to put follow-up of multiple medical issues, or follow-up of diabetes and the Alzheimer's, whatever you want to do. Keep it brief. The chief complaint, again, is the concise statement explaining the reason for the visit. You do not or should not elaborate under this. You will do that elsewhere. Okay, we'll go on. Now, on to the HPI, history of present illness. You will see this paragraph all the time. Chronologic description of the development of the patient's present illness from first sign and symptom, blah, 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 blah. Well, okay. That's how it was presented in the world of acute care when you're coming in with a new problem. But, again, in outpatient medicine, whether it's internal medicine, family practice, geriatrics, whatever, often we are looking at the status of chronic conditions in addition to an acute problem that may or may not be present. So I really want you to get in on this status of chronic conditions. So your HPI will really be a summary, and I like to list it. You know, what's the problem? Number 1, Alzheimer's. Boom, it'll be a summary of where things stand there, the meds were used, and what happened over the intervening month, whatever. Number 2, hypertension. Geez, what's going on there? Number 3, osteoarthritis. Just spell those out. Those are the conditions that you're reviewing, and then if there's a new problem, like they got a backache, new onset, okay, put that number 4. But spell out what those chronic conditions are and the status of those. The HPI elements, when you look at this, this is what we all learned back in training in the first year of clinical medicine, location, quality, severity, on and on and on. Again, this is for when you are digging deep into the description of a particular symptom. So if someone comes in and they really need to just talk about this one new problem of shortness of breath, yeah, we want to give good detail about that. But those are the unusual visits, at least in primary care practice. Back to the issue of summarizing the chronic problems. Yes, the visit must necessitate evaluation while you're explaining why, what's been going on, why you're seeing them this time, and that will often come out in the assessment plan because that's where you're going to put what you recommend. You can pretty much put whatever you think is important to summarize that chronic condition, and you do want to give the status of that. Is it fairly stable, getting worse? What are the issues, the difficulties they're having managing their diabetes? However you want to word that. So there are basically two types of HPIs. The brief HPI, we're looking at, if you're talking about just one symptom, you're just giving a few, 1 to 3 elements of that new symptom, or the status of 1 to 2 chronic conditions. In this example, they're talking about the dull ache in the left ear. Okay, they give you a few descriptors of the ear pain, and depending on how many you have, you will meet the criteria for that, for the HPI for the acute problem. The extended one, note here that when you're talking about a new problem or a specific symptom, it should describe 4 or more elements of the present HPI. And then under the 1997 documentation guidelines, it specifies more that you're looking at least 3 chronic, or it says inactive conditions. I think that's kind of a misnomer. These are chronic ongoing conditions. I want you to really focus on that because, again, that level, the 99214, that is, should be the most commonly used when you're taking care of seniors with multiple medical problems. And so under your HPI, you can pretty much count on summarizing 3 chronic conditions. In this example, again, using the ear pain, they're giving you 5 HPI elements. Dull ache in the left ear over 24 hours. He was swimming 2 days ago, and it goes on more and more. Again, this is important if you're trying to get at a certain level and your work justifies that level when you're talking about a specific symptom or new problem. So just before we move on, to summarize the HPI in primary care when you're dealing with multiple medical issues, as you are for most of the older, frailer seniors that you're taking care of, think of a good summary of those chronic conditions, and then you add on, you will have to make the judgment of whether how much attention you focus to that 1 or 2 problems that you pick up in the history or perhaps on review of systems, or decide, geez, do I have to give more attention to these 2 acute problems and the 1 or 2 of the chronic conditions you might have to address later. You're constantly making those judgments, but know that for the most part you're going to be summarizing the chronic conditions, and then you will determine if you add on the acute symptoms, if there are any. Now, on to the review of systems. It's basically an inventory of body systems where we're asking a series of questions where we're trying to find new issues that we should be tuned into. It's divided into all the major categories. You all are familiar with these. And think of generally 3 types of review systems. The problem pertinent, number 1, where you want to hone in more on that particular problem. In this example, the earache. So you're asking what could be related symptoms. In this example, it's dizziness, tinnitus, fullness, or a headache, in addition to the specifics that you cover in the HPI about the earache. In the extended one, This paragraph will give you a general guideline about it, but the example I would suggest is perhaps a little misleading, and I'll get there. In the extended review of systems, you're inquiring about the system directly related to the problem, and, big emphasis here, and a limited number, 2 to 9, of additional symptoms. So, for example, in our patient who has mild Alzheimer's, osteoarthritis, and hypertension, those are the 3 problems I'm looking at today, I might wonder, geez, have we really looked at the possibility of overactive bladder? How is the patient sleeping? If she's still very ambulatory, might she have claudication? Does she have some other symptoms, GI, whatever, that might be related to some of her medications? So there are a number of things that if we're giving good comprehensive care, we will select to ask about. We do not have to ask about everything every visit, and I would strongly discourage that. But you want to kind of parse things so that you make sure you're covering some key things that we deal with in primary care over a period of time. Now, this example, as I pointed out, they're talking about, follow-up visit after cardiac catheterization, and then under the review of systems, it basically just gives you symptoms that are all cardiovascular in origin, whereas what we really should be doing is looking at those other systems that we should know about and we want to tune into. Sometimes there's overlap with the key problems, but often there's not. And this is really an attempt to help us be more broad in our approach to finding out what's going on with the patient. A complete review of systems inquires about darn near everything. So back on that list of all the different categories, constitutional, respiratory, ENT, et cetera, you're basically doing the complete survey where you're reviewing at least 10 systems. Now, I do want to also point out, when you are looking at a system, you do not have to cover every symptom within that system. You might cover 1 or 2 in each system. You will get credit for doing the system if you cover at least 1, either a positive or a negative within that system. You will have to be the judge as to how many symptoms within a system you might cover for the visit that day, but you do not have to cover every symptom in every system when you're doing a complete review of systems. Here's a good example of that. So, constitutional, weight stable, has fatigue, eyes, just noting the positive loss of peripheral vision. And you go on down here, you can see that there are positives, some negatives, but in many of these different systems, it's only commenting on one particular symptom. Now, on to the past history. So it pretty much includes almost anything. When it says past history, including experiences with illness, operations, injuries, and treatments. Focus on that treatments, focus on the medication list. This is what the constant challenge we have to provide the best care. Know what meds they're taking so that we can adjust those as we see fit. The family history, there will be times when, even in geriatric practice, it comes into play. But you really have to ask yourself, how often is that? When might it be appropriate? When it is not? And you don't have to worry about addressing that when it's really not adding to your clinical care. Social history, much more frequently an issue, particularly in geriatrics. But you don't have to deal with that. And I would argue that as long as you're making sure you're covering an updated medication list, you have all the criteria you need to cover the past history, no matter what level you're billing at. Okay, so the 2 types of the past history are pertinent and complete. In this example where the HPI is focusing on the coordinated artery disease, the past history just happens to mention the surgical history of the cabbage back in 1992. Well, you get credit for the past history by just going back and tying that into your note. Complete is where you're looking at all components. And let me add again what I said at the beginning. When you're doing a new patient, you do have to have a complete, if indeed you're billing at the highest level. To have a complete new patient exam, for example, you do have to cover past surgical history, past family history, past social history, and the medications. Go ahead. So this is just an example of a very comprehensive family history. When you are taking care of multiple medical problems in your seniors, please resist the temptation to get into all this kind of detail. You might want to, over a course of time, include it, fine, go for it, but do not feel that you should let that distract you when you have too many other important things to take care of. Okay, now the Chief Complaint Review System past history may be listed as separate elements of the history, or they may be included in the description of the history of the present illness. My advice would be to get in the habit of listing them separately. And I think it just helps us as providers to parse it out like that. It helps minimize the confusion about whether an auditor would see these as part of these components or not. You can, if you have a very good history, incorporate all this, but I would encourage you to label them separately and address them separately. A review of systems or past history obtained during an earlier encounter does not need to be re-recorded if there is evidence that the physician reviewed and updated the previous information. So you can look back at what you did, and if you know that there's no new information, you can note that what applied 2 months ago still applies today. You have to refer to that note, but you get credit for doing it currently if there is no new information that you have to do it. Similarly, well, I think it's, let's go to the next one here. It can be recorded by ancillary staff or by the patient and their family. So in our practice, for example, we have a very comprehensive patient questionnaire that covers darn near everything. And those good souls who take the time to do the homework, we thank them profusely for doing that. And then we can make the choice, depending on how much time we have during that visit. Do we take each individual component and get it into our electronic health record? In the ideal world, we do that. Or alternatively, do we scan in the comprehensive questionnaire, and then when we hit those different components, whether it's a family history, review of systems, whatever it might be, we just indicate, please see completed questionnaire, and then in the assessment and plan, we address those problems as we see fit. So you can refer to other documents, whether done by your staff, you previously, or the patient and family, but you do have to refer to them if you are to get credit during the current visit. Okay, next. Oh boy, here we are on the table.
Isn't that a beautiful slide?
That is beautiful. What I want to let's go to some practical advice here. All right. So let's talk about a simple level one problem visit. Problem focused. You'll notice there. Well, first of all, this table doesn't even have the chief complaint. Why? You have to have a chief complaint for every visit you do. All right? So take that one off the table. Consider it done. Now, under your HPI, note that in that problem focus is the status of one or two chronic conditions. Again, it could just be one. Or if you're talking about a new problem or a symptom, it can be very brief. Given just 1 to 3 elements about that. You do not need a review of systems. You do not need the past history. And when you get to your assessment plan, you indicate what you're going to do for that one problem. Move to the next one, the expanded problem focus. So this is our next level up. Again, you're talking about 1 or 2 problems. I like to think of it as 2 problems. Level 1 is 1 problem. Level 2 is 2 problems. If it's a symptom, on one of those 2 problems, you're given some description of that. The review of systems for this level visit, you only need 1 system reviewed. You make the judgment whether it's pertinent to the problem. Sometimes it's more appropriate to pick a different system that might be related or at least should be addressed at some point. You do not have to have a past history here, though I will tell you in our practice, even at this level 2 visit, whether we're in an assisted living nursing home or the clinic, we're in the habit of getting that medication reviewed. So this is one area where we might go a little overboard because we just think it's good care and it's a habit we all want to be in. And then in your assessment and plan, you're telling what you're going to do for those two problems. In the next level, again, this is the bread and butter. This is the 99214 out in the clinic that many of you are and should be doing frequently for your older patients that have a number of things going on. Think about the status of 3 chronic conditions, or if you're going into depth about a symptom, you have to have a fair number of elements. And then you have to decide if you're going to combine the new problems with the old problems. Review of systems, again, it's what we call extended. It's 2 to 9. It does not have to be a full 9. It can be 2 if you believe that that is clinically appropriate. You do have to have your past history here. And again, I emphasize, make it a medication review for the most part. I will note in this last category, level 2 and 5, it is hard to meet criteria for that level visit based on E&M criteria unless the patient's pretty sick. That's a general rule. It's hard to, I mean, yes, you can do a complete review of systems, you can do a complete exam, you can do all this, but your history has to justify that, and unless the patient's either pretty sick or has a problem such as progressive fatigue that would justify a complete review of systems and exam, it's hard to, you know, even though you're spending a fair amount of time reviewing all these chronic problems, dealing with a bunch of different issues, it's hard to get to that level based on E&M criteria. It is not hard to get to that level if you're spending the time based on time-based billing. That's a different topic. But here we're saying on E&M criteria, it is kind of tough to get to the 2 and 5. Okay, so we tie it all together. Next. And here's just an example. A gentleman with bilateral knee pain on the history gives us some detail there. In this case, in the review of systems, they're tying in, it's not just an elaboration on the musculoskeletal, it's talking about related systems that might be affected by this HPI, the knee pain. So, for example, they're saying he doesn't fall. He's not having the GI distress that you might wonder about taking the ibuprofen. In his past history, they're given an update on the medications. Key points. Insufficient documentation of any subcomponent can and often does result in incorrect coding of the entire service. You want to know what at least the basic minimum is for each component and make sure you get that. And the best care, in my opinion, is when you can do this reflexively. That allows you to really be present to the patient, to really you know, help them fashion a plan that will help them have a good time, really be good and enjoy the patient visit when you're not having to kind of count all these little things. So you do have to practice this enough and know the rules so that they just happen automatically. Next.
I believe that is it,
Is that
Dr. Murphy.
okay?
All right, let me click over here to our control panel, and we will see if anybody's got any questions. And if you do, you can go ahead and type those into your control panel, and we will address them. I don't see any right now, so I'm just going to move on to remind you about all the great things we have for your use on our website. At coloradomesa.org, you can see we've got a lot of workshops scheduled right now. We're going to be making a trip up to the northeastern part of Colorado next week, and then Dr. Murphy and I will be heading out west along I-70 and making a number of stops. We're also going to be scheduling this fall, actually this fall's about over. Yeah. Snowing here. You had a little snow in Denver here today. Over the next few months in Boulder County, Fort Collins and Loveland, so go to the website and look for that. You can also see handouts, archived webinars, all kinds of stuff there. And I do see one question here coming in from Joe. Can you use time-based coding for all visits?
Well, good question. Technically you could, if indeed you have a practice where you're spending, you know, every visit you're spending good time, and greater than 50% is counseling and or coordinating care. But I would discouraged from doing all visits based on time for two key reasons. Number one is that in doing so, you will not allot enough of your time to take care of the more acute problems, the ones that don't necessarily require 25, 35, 55 minutes, whatever we do. And number two, well, really, that's the main reason. Well, okay. The second would also be this. You are going to, on at least a fair number of visits, be able to accomplish what you need to accomplish more efficiently billing based on E&M than on time. The time should be used when you're having to spend a fair amount of time. So as a general rule, if you're billing at that highest level, let's say in a clinic, and you're spending 40 minutes face-to-face going over all kinds of different things and documenting those discussions, and you can put time of visit 8 to 8:40, greater than 50% counseling and or coordinating care, you definitely want to bill that one based on time, not on E&M, because it's harder to make the 215 the highest level on E&M. It's appropriately done based on time. But or you might have a 25-minute visit where you're dealing with one major problem and you don't meet the E&M criteria, but you're spending that time, bill for that based on time. But I would say if you do all your visits based on time, you are missing opportunities to help your patients in a more efficient way, and the revenues to your practice will not be as good as if you learn how to balance the long visits with the shorter visits.
That's great. Thank you. And just as an aside, we do have a full webinar on time-based billing as well. It's called Nuances of Time-Based Billing, and you can find that in the classroom section on the website. So if you're interested in that, go and check that out. Our next webinar will be Friday, November 2nd, which is the first Friday of the month as always, and we're going to focus on audits. We have a special guest speaker, Mary Ferretto, and she is the actual person that is doing the hands-on auditing for the MESA Progress Note Review program. So she's going to talk to you about how to be prepared for an audit, and we'll give you more information about how you can participate in that program, whereby you can submit your notes to be audited, and she'll give you confidential feedback one-on-one about how you're doing on your notes. So hope you can join us for that. We will see you in a month or perhaps out on the road. Take care, everybody, and thanks for being here.